coffin cases.
That's right. Yes. Yeah.
Dr. Sushil, I just wanted to ask you, your idea of doing BD Glen is just to avoid SVC obstruction? What is the idea of doing routine BD Glen in this?
Right. We adopted this procedure just because the first few patients in our series were those with dextrocardia, and we found it that this was much easier to do than a sending operation. And it was a shorter cross clamp time, and then the physiology worked out very well. We didn't have any problems with, and then we sort of started adopting this approach on a more uniform basis. And those were really the things that drove us to adopt this as a uniform approach. Shorter cross clamp times. There is really no evidence that 1.5 repair is in any way inferior to a 2V repair. The longevity of the conduit, which has been proven again by Mohan Reddy's. They published a paper on that, and one of the biggest advantages is you're avoiding or decreasing the suture load on the right atrium. So that way, the incidence of arrhythmias in the long run is also lesser.
See, this sounds very simple and very attractive when you especially the crack analysis presentation.
Right.
I had one personal experience. It's not very easy because in children we are actually trying to go across. I got a lot of concerns with this technique, though it theoretically sounds very attractive. One, you use a prosthetic patch which has got a very fixed dimension. And what is going to happen when the child grows, nobody knows. And this suture load, what you're telling, you have to traverse the whole of the floor of the atrium and come across. And actually going across is not easy. The case which I did had some residual leaks in that area. And with the whole ventricular mass sitting there, you know that replacing a valve in that is not easy. So going across that area also I found it very difficult.
Really? Sure. I mean, your concerns for...
And third thing, this child ended up having a lot of arrhythmias.
He did? Okay.
So
well, it may be true. You're obviously experienced it, but what I can say is, if you think of the lateral tunnel fontan, where half the pathway is made of the native atrium, it's the same principle really. And there is no evidence that the floor, if you observe, the floor forms about 50% of the pathway. So I see no reason why that would not grow with the patient. And what we have done is we have placed suture marks. So one is at the far end of the tricuspid valve, just below the left pulmonary vein. And then we do 4 or 5 suture marks and we just follow the track. Instead of trying to decipher the track as you walk along, place 4 or 5 suture marks and then just lift one and keep rolling it.
But what do you think of this? The whole baffle is prosthetic material. So do you think it will sort of flatten out as the child grows and have some...
Yes, it is just like a fontan, right? Because that's what lateral tunnel fontan does. Okay. If you really think about it, you're actually just baffling the IV's return in a superior direction. You're just baffling it in a lateral direction, really. So, what?
Dr. Sushil?
No, so if you notice, I'm sorry, the pictures are not the best. The floor is completely free.
They're trying to take the baffle patch all around the tricuspid valve and then from the IVC and all around the tricuspid valve. But the annulus will not grow. Medial aspect is free. Okay.
Yeah, because you see, you are right about the patch covering that, but the floor is formed by native tissue, right?
No, so the growth of the tricuspid valve will be posteriorly that time, medial and posterior?
So I'm not really encompassing the tricuspid annulus. True, we do skirt the tricuspid annulus, but as we come anteriorly, the patch comes on to the IVC.
Okay.
Right?
At what age do you recommend this procedure?
Our approach has been to buy as much time as possible. Generally between 2 to 3 years of age is when we subject the patient. If we have to do it at an earlier age, we do it, but generally that is what we would consider a favorable time.
And one more doubt.
Yes, sir.
If the patient has a complete heart block, what would be your strategy in this patient? Because you have put in a BD Glen. So complete heart block, you cannot put a transvenous spacing wires, you have to put a epicardial pacemaker.
That's
you
right.
Cannot have...
That's right. I would place permanent epicardial electrodes.
Permanent.
That's right.
Permanent.
Yes.
Dr. Sushil,
Yes, sir.
thank you for your excellent presentation. And
For the heart block. So if you look at the approach that's been adopted at the Emory Clinic, Dr. Kirk Cantor and group, anytime they go in for any sort of intervention on a corrected transposition, they come out with permanent leads. It doesn't matter even if you're just doing something like a closure of a VSD, even if the patient has normal rhythm, because we know that in the long run they are at risk of heart block. So what we do is we place permanent electrodes. That's what I do even if the patient is in normal. I tunnel it into the subcutaneous area and just leave it there. So that if I need access, all I need to do is make an incision there and just directly connect it to the...
Few things, Dr. Sushil.
Yes, sir.
Number one, Emi mustard is actually quite easy to do and you will be very roomy, quite roomy, definitely. And it's very good for complex situations, there is no doubt about it. And answering his question, is that I don't think there will be any problem whatsoever diverting IBC to RV. So that's been our experience. Number two, in order to avoid higher gland pressures, you'd better offset the gland towards the hilum rather than towards the towards the central PS. So that will actually lower your, pressures, gland pressures.
That's an
That way you
excellent
can
point.
avoid the pulsatility, and in fact, even the IJB also you can see the pulsation. That
Right.
can be avoided, and it will be troublesome for the patient to keep complaining IJB pulsations.
Right.
And thirdly, I do accept with Dr. Rajesh Sharma. In fact, one of the main reasons for failure of Restylane is the restrictive VSD, over a period of time. And that's why the Boston series, one of the cause for reintroduction LVO2 is that VSD progressively becoming, restrictive. I think this concept of this two outflows will definitely give us problem. I think we may have to find out something alternate for that.
No, you're right. I'm not advocating that we do a double outflow in the presence of and accept a restrictive patch. What I'm saying is that if we know for sure that the VSD is small, then I would still advocate that we enlarge the VSD. I'm not using this as an option, but suppose you did not enlarge and then as you finish, when you eyeball, you feel a little concerned, then at the time of pulmonary transection, what you do is just add a Gore-Tex graft and come out. But I completely agree that VSD enlargement should be done if there are concerns by, standard excision of the muscle, and then that's cannot be substituted by a DK's procedure. I completely buy that. Yeah.
Thank you.
Yeah.
Reddy, 1 minute. How did you say that shifting the gland onto one side would reduce the venous pressure?
What happens in these situations, when the ventricle ejects, if it's directly onto the MPA, towards the MPA, the jet directly towards the gland directly into the SVC. So you offset it towards the hilum, the jet will not get. Yeah, it does.
Yes,
It
that's
does.
right. That's
No
right.
doubt about
Yeah.
it.
Yeah.
Always offset as much towards the hilum as possible.
Yeah. I feel that this is an excellent procedure for especially, somebody who is starting
Especially
out with...
in complex situations, really very,
Right,
very
right.
Emi mustard, believe me, is easy. I feel is the
Yes,
easiest thing to do,
yeah.
and it's quite roomy.
Yes, I
Very roomy.
completely...
Never have a problem with Emi mustard.
Yeah, I can tell you we have not had problems at all. We were pleasantly surprised by the results, and I can tell you that the gland pressures, it does make you nervous in the first 24 hours, but patients just seem to do fine.
It's better to have swelling after Glen than to have swelling after sending. Because after sending it, you are to blame. After Glen, you are not to blame. Right.
Okay. Thank you all so much.
Okay. Thank you very much. I request everybody to stand for the national anthem. So tomorrow, what is the time by consensus being on conference? Okay. 7. So tomorrow, shall we say 7:30? 8. Okay. 8 o'clock here on the dot. Right.
7:30 will start breakfast here, so it's better to start 7:30 and 8 o'clock will start.
You can skip breakfast at home and come here for breakfast. And now dinner. Now we can all gather together and go for dinner at Lemon Tree. Right.
The main gate.